Good morning. I see the clock has struck 10 a.m. So I see also we're having still gaining participants. We're at 175 and going up. But without further ado, I would like to give a few words of welcome and introduction. And then from there on, the colleagues from WHO Barcelona, PASH, will also guide the further debate of today. My name is Dick van der Steen. I represent the European Commission, DG Santé, and the unit that has the pleasure of working with the colleagues from WHO Barcelona on the topic of accessibility and financial protection for healthcare. So today's webinar is part of our overall EU for Health action on affordability of healthcare. And actually, this is the second policy dialogue that we host under this action. We decided to dedicate it to discussing the impact of aging on the financing of health systems and access to healthcare based on what we know on population aging, what it could do in terms of the revenues for health systems and the impact on low income groups. Now, I would like to have a few opening words and only 4 to 5 minutes, no panic, but just to give a bit of a broader framework. And I would like to say by saying, in the wider scheme of things, if we look at the EU, we have a relatively strong position when it comes to social protection and access to healthcare. We should be proud of this. And this was also in the Draghi report on EU competitiveness. So that also talked about social protection. And it said that the EU's approach has delivered outstanding outcomes, including in terms of health, mentioning also life expectancy in the EU and comparing it to other constituencies, jurisdictions. This is also, for instance, clear when we look at some of the recent work done by Eurostat on how much poverty is avoided in EU member states by the fact that we have public coverage for healthcare. However, there are certainly already at the moment gaps that need to be addressed. If we look at the population reporting on medical needs, by and large, this is 2.4% of the population reporting such unmet needs. But if we adjust it and only look at the population that declare to have a need, so they actually need it, it already goes up to 3.5%. And there are countries, when we look at unmet medical needs, where more than 10% of the population reports unmet needs. We also know there's an economic gradient with the poorest income groups facing 4 to 5 times more unmet needs than the highest income groups. And then if we look at the out-of-pocket spending for healthcare, the burden on households, this accounts for over 14% of healthcare costs. So certainly there are gaps already currently. Now, if we look at the future, and this is what today's discussion and webinar does, it peers all the way into 2060, and then we're talking about the impact of aging. And if we look at the impact of aging, we know it will impact the demand for healthcare. And we know this because at the level of the EU, we have been publishing the cost of aging reports. At the same time, we also know that if we manage to add life years in good health, then the public cost for healthcare as a share of GDP, we can stabilize it between now and the very long future. And that, of course, further reinforces the priority given to prevention in the mission letter for the new health commissioner. At the same time, when we talk about demographic aging, and this is why today's debate is very relevant, because it presents a unique feature in the analysis in the domain, we also need to think about how will aging and of the population impact the revenues for the health systems. And that may vary quite a lot between the member states, depending on whether you rely on social security contributions that are linked to employment status or not. And one of the lessons also we learned recently from the COVID crisis is that gaps in access during times of crisis, they will hit vulnerable groups the most. That is a clear lesson we need to draw upon. So if we take all these points together, we know currently we have gaps in access. We know demand for healthcare is likely to go up, although we may stabilize it if we have prevention. But we certainly know there is something to be said about the revenue side for health systems. And at the same time, we know we should be very concerned about low-income groups and vulnerable groups. Then today's debate, the policy dialogue, is very timely and relevant because it will explore exactly these scenarios. What may happen based on what we know on the constant policy scenario in terms of impacts as regards catastrophic spending for low-income groups based on demographic aging. Not just the demand for healthcare, but also how do we fund our health systems, and that's a very important feature. Now I will conclude. We see this action and today's debate also as part of our commitment, the Commission's commitment to the European Pillar of Social Rights Action Plan. And the European Pillar of Social Rights, we have a Principle 16 on access to healthcare. We also look forward to updating this action plan in the coming mandate. And at the same time, we will continue and maintain our analysis and our advocacy under the European semester in assessing the performance of health systems, and certainly when it comes to accessibility. So I thank you for your attention. I look very much forward to the debate, and I leave the floor to Tamas now. Thank you.
Thank you, Dirk, from the European Commission for this great introduction. And thank you everyone for joining this webinar, where we will discuss health financing policy challenges in the context of aging populations. My name is Tamas Evetovic. I'm the head of the WHO Barcelona Office for Health Systems Financing, and I have the privilege of introducing this webinar on behalf of our office and my three colleagues, John Silas, Sarah Thompson, and Lynn Altair. John will deliver a presentation of the topic, and then Sarah and Lynn will moderate the discussion afterwards, including three distinguished panelists, Jan Kiel Amgar, who is at the Ministry of Health and Social Policies of France, and the former DG of France's Central Agency of Social Security Organizations, Maris Jesse, former Deputy Secretary General of the Ministry of Social Affairs of Estonia, and Joe Kutzen, former head of the Health Financing Unit at the WHO headquarters and former head of the Barcelona office. So how does population aging affect financial sustainability and affordable access to healthcare? To find answers, we use PASH and CATA. I'm sure you're keen to learn what these acronyms stand for, and hope that some of you are already familiar with them. While population aging itself is not the main driver of health expenditure growth, it does have an impact on health financing, both in terms of revenues and expenditures. The most important question is who will pay for it if there is a gap in financing needed healthcare. Of course, households will pay for it in one way or another, directly or through taxes or potentially through private insurance. As always, the more important question is the distribution of the burden. Which households and to what extent will cover the gap in financing? Rich and poor, healthy and sick, older and younger, employed, unemployed, etc. In order to have a meaningful discussion, we have to have some data. First of all, to understand the magnitude, the size of the financing gap. For this, we use the PASH simulator. PASH stands for Population Aging Financial Sustainability Gap for Health Systems, which was developed by John Silas and colleagues at the European Observatory in collaboration with the WHO Center in Kobe, Japan. John will provide a short illustration of how PASH can inform us about expected revenues and expenditure of public funds if there are no changes in the current revenue-raising modalities and expenditures other than age-related patterns. Then the next question is how to cover the gap and what can be expected if the gap is covered through out-of-pocket payments instead of public funding. This is where the work of the Barcelona office on monitoring financial protection, affordable access to healthcare, provides insights to the financial hardship experienced by households due to out-of-pocket payments in countries with different levels of out-of-pocket expenditure and different coverage policies for protecting people from financial hardship. Our work on monitoring financial protection covers more than 40 countries of the European region, and by now we have quite robust evidence on what explains good and bad performance. If you're interested in more details, please visit our online platform called UHC Watch, where regional and country-level evidence for more than 40 countries are available. So in this session, we bring together PASH and CATA. CATA stands for catastrophic expenditure by household. We look at public and private out-of-pocket expenditure trends in different countries and the impact on households and government budgets. John will present the findings of our analysis using projections up to 2060 and illustrations from 5 countries. Then Sarah will moderate a panel discussion with support by Lynn, managing questions from the audience. I trust you will have a very enjoyable webinar. And with this, I hand over to John for his presentation on the topic. Over to you, John.
Thank you, Tamás. Thank you, Dirk. Let me just share my slides. So, yes, so I will present the key findings from this report that we've released today. So I think there's lots of policymakers everywhere are worried about population aging and how it will affect health financing. And there's this assumption that this is an inevitable catastrophe for the sustainability of health systems. And so the question is population aging an inevitable disaster? And the answer is it depends. If we look very simply at data on health spending by age, of course, older people on average use more health services than younger people. Spending is higher on behalf of older people. So one might think that having more older people could increase spending substantially. Now, when we look at the data, we see that even in countries that are aging considerably, the contribution of population aging to expenditure growth is roughly between 0.5% per capita to 1% of additional growth per year, but still it's putting upward pressure over time. At the same time, and Dirk mentioned this a bit as well, revenues could decline. The money that's raised for health could decline due to aging, especially if there's an over-reliance on the working age population to generate funds. So through employment, social contributions linked to the labor market paid by on behalf of employees. So as the workforce shrinks or people at working age declines as a share of the total population, this could lead to a decline in the revenues raised for healthcare. Now, I said it depends because policymakers can take steps to prevent financing gaps due to aging. They can, as Dirk mentioned, they can invest in prevention. They can try and eliminate low-value care. They can use payment mechanisms to incentivize providers to provide low-cost, highly effective solutions. And they can also change, of course, the way that money is raised for healthcare. They can diversify the revenue base instead of relying predominantly on the labor force to finance healthcare. But what if they don't? And this is the key question of this work. So if people continue to use healthcare in the same way that they do now, then it implies that more healthcare costs will be paid out of pocket. So people will either pay more co-payments or higher co-payments to use publicly financed healthcare, or they'll pay directly out of pocket to use private care, private services. And this greater reliance on out-of-pocket spending could have implications for household finances, and it could have implications for affordable access to healthcare, which we capture by looking at catastrophic and impoverishing expenditures as key indicators, both of affordable access to healthcare and ultimately of progress towards universal health coverage. So how can we better understand this issue? Because at this point, this is very theoretical. So we have this report, which is released today, where we forecast the size of the aging-related health financing gap using the PASH simulator in 5 countries. And what we do is we see how aging in these 5 countries affects the ability to generate revenues and how it affects expenditures. And then we take that gap and we turn it into monetary terms, and we estimate how much out-of-pocket spending would need to increase to fill the financing gap. Then we estimate how much this increase in out-of-pocket spending would affect the risk of financial hardship for households based on current coverage policies that are in place. So we look at the distribution of out-of-pocket spending in countries, and we assume the households that are spending have to spend more than they currently spend now. So how does the PASH work exactly? So the PASH is a very simple simulator. So it asks, what if the way that we fund health systems and the way that we spend stayed the same forever, but the age mix of the population changed? So we still spend more per person if you're a 75-year-old male who's consuming, let's say, 7 times as much healthcare as the average 35-year-old male. We can assume that that stays constant forever. Same for taxes. We assume that people at each age contribute the same amount of taxes in social contributions and income taxes in VAT as they do today. But the mix of the population changes in terms of the age mix of the population changes. And what this enables us to do is isolate the impact of population aging on health financing. Now, I have a QR code in the upper right-hand corner. This is if you want to use publicly available version of the PASH, which is a simpler version than the one that we use for this work. But effectively, you're able to choose a country which has its own population by age forecast. You're able to see the mix of taxes that are used for health, and you're able to choose health spending by age profile. So in the work that I'm presenting today, I'll present the actual data from these countries disaggregated by males and females. In the online version, you cannot do that. These are hypothetical spending by age curves, and you can see how how aging affects and the change in the population age mix affects revenues and expenditures over time. And you can explore how different policies, different changes in the income in taxes that are used to pay for healthcare and changes in spending patterns could potentially fill the gap over time. Now, in this study, we've chosen 5 countries that represent a diverse mix across the EU. We've chosen Spain, Italy, Slovakia, Slovenia, and Bulgaria. We chose these countries because they capture a lot of the interesting characteristics that we think are important for this analysis. So Spain and Italy have very high percentages of their populations over age 85. So by the end of the forecast period, by 2060, they both are expected to have approximately 9% of their population over age 85. So one might think that that would lead to substantial increases in health spending, potentially. We also have 3 countries which have a high reliance on social contributions to finance healthcare. So as we've mentioned, these are social contributions are linked to employment, so very heavily linked to the working age population. And as the working age population shrinks, the ability to raise revenues from social contributions shrinks as well. So Slovakia, Slovenia, and Bulgaria. Slovakia and Slovenia both depend on social contributions heavily, but Slovenia depends much more highly on social contributions to finance healthcare. So and we'll see how much in the next slide, but Slovenia has the highest reliance on social contributions to pay for healthcare in all of the EU. We also have Bulgaria, another country which, relatively speaking, relies heavily on social contributions, but it also has the highest reliance on out-of-pocket payments among all the countries in the study. So about 1/3 of health spending is coming from out-of-pocket payments in Bulgaria, and as we'll see in a second, much lower in the rest of the countries. So we felt that this captures a broad mix of countries, gives a rough idea of how different financing arrangements and different exposure to population aging will affect our results. So here we have data for the countries, so we'll jump right into it. So on the left, these are data from national health accounts for the 5 countries plus the EU average in terms of by financing agent. So who's spending the money? So we can see here that in the EU countries, predominantly spending is coming from public sources. This is in green. As I mentioned, Bulgaria on the far right has the highest reliance on out-of-pocket spending. About 1/3 of its spending already is coming from out-of-pocket spending, and the rest are much lower. The big exception, I'd say, is Slovenia, which has very low out-of-pocket spending, but according to these data, has very high voluntary health insurance spending, which covers, at the time, covered co-payments for publicly financed services. Since that time, since 2024, voluntary health insurance has been replaced with a levy, but we're using data from 2022. On the right-hand side, we have data on our estimates of where the money comes from, so the different mix of taxes that are used to finance healthcare. We can see in Italy and Spain, these are predominantly financed through general taxation, so an even split between taxes on income, profits, and capital gains, and taxes on goods and services for the most part. And as I mentioned, Bulgaria, Slovakia, and Slovenia have to varying degrees a reliance on social contributions. So Slovenia has the highest reliance, around 80% of its public expenditure on healthcare is coming from, in 2022, coming from social contributions paid by the workforce, slightly less than this in Slovakia, and a bit less, closer to 45% in Bulgaria. Now, spending by age also, of course, is an important driver of these estimates. These are data that come from the Aging Working Group of the European Commission for the 5 countries, disaggregated by males and females. So this is per capita spending. Generally, I would say that these follow very similar patterns. So if we look at the far left, so children, babies are very expensive, people in the first years of life, and then this falls dramatically. And over adolescence, young adulthood, with the exception of some bumps at younger ages, there's, generally speaking, this is fairly smooth. There's a little bit of a bump in the late 20s and 30s among females having children. But generally speaking, it's around middle age when we see that spending by age starts to increase per person. Now, this increases to varying extents. You can see that in Italy, Slovenia, and Spain, at older ages, the per person spending is the highest. However, relative to spending at younger ages, actually, Slovakia has the highest per person spending, at least for males, compared to younger populations. So if we looked at the average 75-year-old male, the public spending on an average 75-year-old male is about 7 times that of the average 35-year-old male. And these ratios are lower in the other countries, more closer to 5, maybe 6 times as high. Now, if we combine the population forecasts, the tax revenue data, and the mix of taxes, as well as the health spending by age, we're able to do the PASH simulation. So we index this to the base year. In this case, this is 2022, where we assume that revenues and spending equaled each other. And then from then on, there's a financing gap. And so in the darker color blue, this is health spending. In lighter is revenue. This is on a per person basis. And so we can see how population aging on its own with no other changes will lead to gaps in countries due to the changing age mix of the population. Now, the biggest gap is found in Slovakia, interestingly, where we can see here it's largely driven by a mix of spending and some increases in spending. So spending is expected by 2060 to almost be 30% higher than per person spending in 2022, just due to aging. The revenue is also expected to decline substantially by more than 10% per person. In Italy, Italy is expected of the 5 countries to have the smallest gap, where spending increases by a little bit under 20% compared to the baseline year per person, but revenue stays relatively flat. And this, of course, just to reinforce already, is due to the fact that Italy's health system is funded through a broad mix of taxes that are relatively impervious to population aging. If we look across all 5 countries, we just compare 2022 to 2060, the end of our simulation exercise, we can see that the largest gap, so this is sorted from left to right by the largest gap on the left, the smallest gap on the right. Largest gap, again, is in Slovakia. We can see how much of it is due to spending versus revenue, followed by Slovenia, then Spain, then Bulgaria and Italy. Interestingly, I think in Bulgaria, even though it has the second smallest gap, it's almost evenly split, being driven between spending and revenue. And as we saw in the slides earlier, showing the health spending by age, health spending levels, as well as the increase at older ages, is much smaller in Bulgaria compared to other countries. Now, we take this gap, as I mentioned, and we convert this into monetary terms. So we estimate the euro amount that would need to be paid out of pocket by households. We assume to fully fill the gap. And so what we do is, for each year, we estimate a multiplier of how much per person out of pocket spending would need to increase to fill the financing gap. And so here, for example, we see in a country like Slovenia or Slovakia, the average household would need to spend 2.6 times as much out of pocket as they do currently to fully fill the financing gap. In Spain, it's about 1.9 times as much spent by the average household to fill the financing gap. In Italy, about 1.6 times, and in Bulgaria, just under 1.4. And this reflects differences in the level of spending as well as the size of the financing gap. So the question, once we've reallocated, we've run the simulation to see how much each household would spend in addition if they were filling the financing gap. We then rerun our estimates of catastrophic and impoverishing spending to see what the influence would be, the effect would be on the incidence of impoverishing and catastrophic spending. So here we have impoverishing spending through 2060. So these results are sorted from left to right, with the countries on the left being those which have the largest relative increase. So Slovenia, even though it's coming from a very low baseline of less than 1%, is expected to have an increase in impoverishing spending up to around 1% by the end of the forecast period. The smallest increase is in Bulgaria, but Bulgaria already has very, very high levels of impoverishing spending. So impoverishing spending in the base year is about 8%. This is forecasted to increase to around 10%, a little over 10% by the end of the forecast period. And this relatively small increase is both due to the relatively small financing gap, but also due to the fact that many households who are likely to be impoverished are already impoverished at baseline. So if we look at Bulgaria, we'll see this again in the following slide. In Bulgaria, more than 90% of households are spending out of pocket already. And so those households which can't afford to spend or which are easily impoverished by spending very small amounts, these households are already impoverished. And so even an increase in spending in Bulgaria, it deepens the impoverishment in these households, but it doesn't massively increase the incidence, although the incidence is still the highest among the countries. Alternatively, if we look at Spain, Spain has the second lowest relative increase, but also it has very low impoverishing spending, starting off around 1% and increasing to around 1%. And again, similar to, as I mentioned in Bulgaria, where I said that everyone is really spending out of pocket, including the poor. In Spain, this is not the case. In Spain, compared to Bulgaria, where more than 90% of households spend out of pocket, in Spain, it's more like 70% and even lower percentages among those in the poorer households who are protected through exemptions and other protective mechanisms. In Slovakia, we also see a fairly substantial increase, same in Italy. The relative increase is bigger in Slovakia, despite the fact that impoverishing spending at baseline is relatively low. By the end of the forecast period, it reaches over 5%. We look at catastrophic spending. So catastrophic spending, for those of you who are not familiar, we define in the WHO European region as households that spend more than 40% of their budget after accounting for the costs of meeting basic food and housing needs. So households that are very poor have a higher risk potentially of experiencing catastrophic spending because they spend much more of their resources on basic needs like food and housing. So they have a very small capacity to pay. And we find that, of course, looking even at the historical data here, the baseline year, where the poor, those in the poorest quintile, which is the darker blue color, they predominantly make up the incidence of catastrophic spending. Again, we see Slovenia has the largest relative increase in catastrophic spending, increasing from very, very small levels to something much higher. Although again, this assumes that the previous system where voluntary health insurance was still covering co-payments is the predominant mechanism, the predominant system in place. We see the smallest relative increase again in Bulgaria, but again, as I mentioned, this is already coming from a very high baseline. And so catastrophic spending is the highest in Bulgaria currently, but also by the end of the forecast period, it's over 26% of households. And while this is, again, predominantly driven by poor households, the increase is not predominantly driven by poor households. Again, because poor households are already spending a lot out of pocket in Bulgaria, so there's not much more space even increasing their spending does not increase their risk of catastrophic spending. They are already catastrophic spenders. Alternatively, we look at Slovakia, which has relatively low catastrophic spending incidence of around 5% at the baseline, but sees almost more than 10% more households experiencing catastrophic spending. It's going from 5% to over 15% of households by the end of the forecast period. And these increases occur largely among the poorest households, unlike in Bulgaria and unlike in Spain, where we see that even though catastrophic spending is increasing, the catastrophic spending among the poorest is actually staying relatively flat. And same in Italy, the increase is relatively small among the poor. It's richer households which are experiencing catastrophic spending, newly experiencing it in 2060. If we just compare the endpoints and look in this time, sorting our data from our results from the largest absolute increase in the left to the smallest, we see that actually, even though Bulgaria has the highest catastrophic spending, the largest absolute increase is actually in Slovakia. As I had mentioned, the smallest increases are in Slovenia and in Spain in absolute terms. I want to talk a bit more about Bulgaria because Bulgaria has, as I mentioned, most of the population is spending out of pocket on healthcare, and it has the highest catastrophic spending at baseline, as well as in the forecast in the simulation at 26%. And so we wanted to experiment, and this is not in the report, this is just in the webinar. What would happen if Bulgaria had better user charge policies? It had more protective user charge policies. And specifically, what if Bulgaria had an Austrian-styled cap on co-payments? So what is the Austrian cap? How does it work? Well, in Austria, the co-payments for outpatient prescribed medicines are automatically capped at 2% of net annual income. So there's no applying for reimbursement. There's no applying for eligibility. Automatically, as you use prescription medicines, once you cross this threshold of 2% of your own net annual income, you no longer are paying co-payments for medicines. There's other caps also on co-payments in Austria, but we don't explore these. They vary by social health insurance fund. So we're only focusing on the co-payments for outpatient prescribed medicines. And more information about this cap and other caps can be found in this good practice brief, which is also released today, which looks at Austria as well as a few other countries. In this particular simulation, because we don't have data on how much of a household's medicine spending is for prescriptions versus over-the-counter, we assume roughly that 50% of medicine spending in each household is for prescriptions, and the other 50% is over-the-counter, so not subject to the cap. And so, if we look first at the data in the baseline year and in 2060, how many households would have exceeded an Austrian-style cap in Bulgaria, excuse me. On the left, we have the baseline year. This is 2018. We see just over half of households on average would have exceeded the Austrian-style cap of 2% of net annual income through as a result of their prescription medicine spending. This is largely concentrated in the poorest 3 quintiles, where about 2/3 of each of the quintiles is exceeding the cap. But also in the 4th and 5th quintile, a substantial percentage of households would have exceeded this cap and spent more than 2% of their net annual income. In 2060, in our hypothetical 2060, where we've forecasted the filling of the aging-related financing gap through out-of-pocket payments, we see that 60% of households would have exceeded the Austrian-style cap, assuming a constant distribution of spending across services. And again, this is concentrated amongst the poorest 3 quintiles, where around nearly 70% in the 2nd and 3rd quintiles, actually more than 70% of those 2 quintiles would have exceeded the cap. So the question is, well, what would have happened if that cap had been in place? So again, looking at Bulgaria, we have here the baseline year, catastrophic spending. Around 19% of households would have experienced catastrophic spending, or did experience catastrophic spending, excuse me. This is historical data. In 2060, if there were no cap using our simulation, we assume that we expect that this would increase to more than a quarter of households, so 26.4% of households would experience catastrophic spending. But if a cap was in place in 2060, this would have restricted out-of-pocket spending such that only 18.1% of households would have experienced catastrophic spending. So still high, still a lot of households spending on other things, spending in our simulation on over-the-counter medicines and other services, but a substantial decrease. Now, of course, this decrease doesn't come without costs. So we've estimated, well, what if that additional spending, instead of being paid by households out of pocket, if that was paid publicly? And so our estimate is that this would account for about 82 additional euros of per capita spending in 2022 prices. Not so easy to say. And 13% additional public per capita spending. So not much in absolute terms, only 82 additional euros per person, but 13% additional spending is still a substantial amount given the relatively low spending levels currently in Bulgaria. So my final slide, just to wrap up with some policy messages. I hope that you can see that population aging does not spell certain disaster for health, finance, and sustainability. And I think this is very clear. You know, Spain has will have one of the largest shares of its population over age 85 by 2060. It has a relatively small financing gap and a really negligible impact on its risk of financial hardship, of catastrophic spending, and impoverishing spending. And this is largely due to the policies that are in place. This is due to the fact that there are good coverage policies in Spain. So there are low caps, there are exemptions. People are not exposed. People that would be vulnerable to increases or susceptible to increases in out-of-pocket payments are not exposed to out-of-pocket payments in a country like Spain. But so if we look, of course, across these countries, without changes to health financing policy, population aging could increase financial hardship. It could cause trouble for financial sustainability for the health system. So what should countries do? So to support health finance sustainability and affordable access, there's a number of things countries can consider. The first is to narrow the gap by broadening the public revenue base and reducing reliance on social contributions. We see that, of course, in the countries that rely heavily on social contributions, Slovenia, Slovakia, these countries face declines in their ability to generate revenues as populations age, as the workforce declines. And even if revenues are not the primary driver of the financing gap, they're an important part of it. In a country like Bulgaria, it's nearly half of the gap is due to revenues. So broadening the revenue base, diversifying, relying on more general tax revenue base, general taxation that is impervious to population aging, like we see in Italy and Spain, this will result in negligible effects on revenue generation over the forecast period. Second option is to, of course, countries can try and reduce their spending to fill the financing gap, but they need to do it in a way that it doesn't increase financial hardship or unmet need. So our estimates here are presuming that need stays the same, that use stays the same. And so any efforts to just across the board cut spending will lead to access barriers. And these access barriers will lead some people not to use services, but others will go private, will spend out of pocket, will pay for private insurance, and they will still find other ways to use these services potentially, but at a cost, at a risk of financial hardship for them. And many people will, especially the poor, may be unable to use services. So any efforts to reduce spending need to be such that they don't actually damage people's ability to use services. So this is through things like potentially preventive mechanisms can reduce spending at older ages in the longer term. Reducing low value care, payment mechanisms that try and incentivize providers to provide better quality services at lower cost. These types of mechanisms that don't actually disrupt access are those that could potentially fill the financing gap. And last but not least, paying more attention to strengthening coverage policy. So I hope that you've seen that in countries that have very strong user charge policy, very strong coverage policies, and lots of protective mechanisms like in Spain, the impact even of a financing gap is negligible on the risk of financial hardship, whereas countries that have fewer protective policies like Bulgaria in particular, these countries do face very high rates of catastrophic and impoverishing spending. My last point is that good performance does not guarantee good performance in the future. So countries should not become complacent. If we look at Slovakia, Slovakia performs fairly well currently, only 5% catastrophic spending, but it's expected to increase dramatically as a result of people spending out of pocket to fill the financing gap because of a dearth of protective mechanisms. And so while good performance does not guarantee good performance in the future, we have to remember also, though, that bad performance does guarantee bad performance in the future unless corrective actions are taken. And we see this very clearly with Bulgaria. So I hope that this has provided some interesting insights. My final slide is just a link to UHC Watch. So we use a lot of the information on coverage policies, as well as the indicators and the data that's in UHC Watch on financial hardship to inform this work. And so please visit it. There are QR codes right here. So thank you very much for your attention.
Thank you, John, for your excellent presentation. That was really, really very clear. I'm sure many of you will want to have John's slides, so we'll put John's slides in the chat at the end of the webinar. And if you have questions for John, please put your questions for John in the chat as well. In fact, put any questions that you have in the chat, because we'll have Lean will moderate them in the Q&A session at the end of the webinar. John's presentation is based on a new policy brief just out today and a new series on improving affordable access to healthcare. And we're also launching 2 other briefs today. John mentioned the one on income-based caps, an important mechanism countries can use to protect people from co-payments. And we have another one looking at the experience of countries that have made this kind of protection from co-payments really automatic using digital tools. So those, I think Lean will put those links to those in the chat. And we've also prepared a short reading list for you all, which we'll put in the chat at the end of the webinar as well. Now we're going to move on to our international panel. We're really pleased to have 3 stellar panelists with us today. I'm just going to reintroduce you for the people who joined us late. So we have Jan Amgar from France, who works for the Ministry of Health and Social Policies in France. We have Maris Jesse from Estonia, who's a former Deputy Secretary General of the Ministry of Social Affairs in Estonia. And we have Joe Katzin, who was once the head of this office in Barcelona, but then went on to work in health financing globally in Geneva, and was the head of health financing at the World Health Organization in Geneva, and is now working for Results for Development. So thank you very much, the 3 of you, for joining us today. I'm going to start with you, Jan, from France. John, in his presentation, really showed us very clearly how countries with social health insurance schemes will lose public revenue for healthcare as their populations age, because people will leave the workforce, and countries with social health insurance scheme traditionally rely very heavily on payroll taxes to finance healthcare. And you understand this challenge very, very, very well, because before you were in the Ministry of Social Affairs, you worked as the director of the agency responsible for social security in France, not just health, but other aspects of social security. And we, in this office, we really love the French story. France has always been our poster child on this issue, because 30 years ago now, in the 1990s, you saw this challenge coming, and you took action to try and address that challenge, to broaden the health system's revenue base. Previously, you relied really heavily on employer contributions, on employee contributions to finance healthcare, and then you introduced a new tax which broadened the revenue base, extended it to income. So could you tell us, Jan, a little bit about the French experience, and in particular, what were the factors that motivated you to make this important shift in health financing, and how were you able to implement these changes?
Thank you, Sarah. Thank you for the invitation, and thank you for the thrilling presentation. About the story about the creation of the generalized social contribution, so the CSG. So the story is basically what you said, that we had a Bismarck-inspired social security system financed mainly by social contributions, payroll taxes on earned income. And in 1991, we created the CSG not only as an answer to a financial crisis, because at that time, in 1991, when we created the CSG, at the time was the social security, which is a budgetary balance, but also to address other challenges in the evolution of our social security system. I would say that the CSG meant to address three different challenges. The first one is fairness in the context of the shift in the conception of social security. We started with a system where the coverage was linked to your professional activity, and we had a trend where we universalized certain benefits, especially family allowance and healthcare benefits. That means that social security cover was more and more linked to your residence in France and less linked to your employment. So in parallel to this universalization of benefits, we had this reflection about universalizing the financing of social protection by making contribute new incomes. I mean to say, not making the financing of social security levy not only on earned income on working people. The second challenge was employment and economical policies in a system where the financing of social security weighs entirely on labor income. It means that the increase of social expenditure weighs only on labor income and increases the cost of labor. And it has several economical effects. It can be difficulty in international competition, and it tends to accelerate the substitution of capital to labor, of machines to men. And the third challenges we had to address was a challenge of sustainability, and there we meet the theme of aging systems. I mean, we saw a declining share of salaries in household incomes. We saw a rising of capital incomes, a rising of replacement incomes, that is to say, pensions and unemployment benefits, in a time in the 1980s when we saw a high rise in unemployment. And we saw as well a rise of additional remunerations which were not subject to social payroll contributions. For instance, profit sharing, employee share ownership, stock options, free shares, employers' contribution to supplementary protection. All these additional remunerations did not generate social contribution on payroll taxes. So we had a challenge because all these new household incomes were taking a rising part of household incomes to reduce the exposure of the revenues of social security to the share of salaries of earned income to reduce the exposure of the revenues of social security to the share of the salaries in the household incomes. So to address these challenges, in 1919 we created the CSG with a very small rate, just 1.1%, broad-based, low rate. And when we create the CSG, it's to finance as well healthcare and family benefits. It has a flat rate with the exception of replacement incomes, I mean to say pensions and unemployment benefits. For pensions and unemployment benefits, we have exemption for small pensions and different rates in this tax depending on the total household income. From this creation, the CSG has been regularly increased, either to bring new revenues in times where we had budgetary difficulties for social security, or when we rose the CSG and when we created the CSG, it was not to increase immediately the revenues. It was just a shift between CSG and classical social contributions. So in the moment when you create the CSG, you do not bring immediately new revenues, but in the long term, you give more dynamics to the revenues of social security. So you had a lot of shifts between CSG and social contributions because it enabled the government to increase the purchasing power of working people, thanks to the broader tax base of the CSG. I mean, 1 point of CSG is 1.7 of social contributions. That is to say that when you rise the CSG from 1 point, you can reduce your social contribution from 1.7 and then increase the purchasing power of working people. So with all these risings in CSG, now CSG has reached from the small 1.1 is nowadays 9.2. It's more than 150 billions. So CSG has reached its goal of increasing the income base of social security and bringing new dynamics to its revenues. But there are limits to this beautiful story, and maybe now we have reached this limit. Now in France, the political debate tends to focus on the global level of taxes, and we have now a very low capacity to accept new taxes, even on the CSG. We have to remember that the CSG on pensions was one of the subjects of our great winter of discontent, I mean to say the Yellow Vest movement 5 years ago. And I can also underline that although the CSG has been created by a socialist government, nowadays the left-wing parties tend to criticize the CSG for its lack of progressivity, for its flat rate. Maybe now, when we are facing rising historical deficits in our social security, we won't have the choice to raise again the CSG, but we know it will be much more difficult than it used to be to use this instrument that we did in the past. So it's an interesting story which shows you that broadening the base of social security can bring dynamics to the revenue. It also shows you the limits of this tool.
Thank you so much. Thank you, Jan. That was really a great exposition of the France experience. And I think what we really love about the French story is the fact that you saw problems in the health system, you saw gaps in coverage that you wanted to fill, but you also saw challenges on the horizon in the broader context in terms of demographic shifts and shifts from wages to income and other issues. And you took action. And I think that's what's really commendable. And it's a really good example for the many other countries in Europe that have social health insurance schemes that haven't yet been able to make that good. Maris, I'm going to turn to you now. Estonia is one of those countries with a social health insurance scheme. It's very much like France was in the 1990s. It's like Slovenia now. It's very, very heavily reliant on payroll taxes, on social contributions to finance healthcare. And like France, in Estonia, you've known about this issue for many, many years. So you know, in 2005, the Estonian parliament asked you and Andres to produce a report on the financial sustainability of the health system. And then 5 years later, with Andres and WHO and the Estonian Health Insurance Fund, we did another assessment for the government of the financial sustainability of the health system. So going back 15, 20 years, there's really been an awareness of the challenges that you face in the health system in Estonia. But I think it's fair to say that it hasn't been as easy to address in Estonia as it seems to have been in France. So can you tell us a bit more about Estonia's experience with this, and especially about why you think it has been more difficult to make progress in broadening the revenue base in Estonia than it has been in France, for example?
Thank you, Sarah, and thank you for inviting Estonia to present our experience. It is not as optimistic as the case of France that we just heard. France has been a kind of a role model for us that we have been striving forward, however, unsuccessfully until now. And despite Estonia seeing the risks of payroll tax reliant health financing system already realizing, we are still struggling to select the way forward. But as most of the audience is not, I suppose, familiar with the Estonian system, then in 1991, Estonia introduced a social health insurance system reliant on 13% payroll tax. And for the first 20 years, it did really serve us very well. It provided a stable base for health care revenue that covered almost 70% of total health spending. The coverage with services was rather good, and the co-payments were regulated. And as a result, Estonia was among the countries with highest increase in life expectancy for the last 20 years within the EU. But we recognized this three challenges that Jan was discussing: the fairness, the employment and economic policies with high labor tax, plus the sustainability to the system. And we have been trying to put with regular analysis, the challenges on the political table with alternatives, how to address the sustainability of our health financing system. And so far, we haven't been successful, I think, because of lack of consensus among our main political our main political parties. Estonia has usually coalition governments. The main political parties being a couple of liberal parties, conservatives, and social democrats. And naturally, the liberals and the conservatives lean towards more like personal responsibility-based solutions, although they have not also been able to offer any sustainable alternatives to supplement the current solidarity-based health financing. And on the other hand, then Social Democrats have been advocating and been marginally successful also in broadening the health insurance revenue base. However, they have not been able to bring along a fundamental sustainable change of broadening the revenue base. But now we are in a situation that we predicted already 20 years ago, that in the years around 2020, 2024, the expenditure in health insurance system will be exceeding the revenue. Luckily, the health insurance fund has reserves to cover the gap for this year and for a couple of next years. So now the Estonian political decision makers are just forced to make decisions. What these decisions will be, we don't know. We just know that from the expert health policy community, we will be advocating for solidarity-based solutions. Thank you. That's like shortly where we are.
In a nutshell, thank you, Maris, for reminding us that it's not always easy to make the changes. It's very easy to say what countries we think should be doing, but actually in reality, politics gets in the way. And even in Estonia, where you are usually very good at finding solutions, it's been quite a challenge for you. I think it's also a good reminder, and this is a nice segue to Joe here, that policymakers do always have choices, and those choices are not always equal in terms of the consequences that they have for different people in the population. And so, Joe, thinking about, this is something that you've talked about a lot. You talked about in a policy brief that we wrote on financial sustainability, actually in 2008, just as the global financial crisis was breaking. And it's something that we reflected on in the work that we did with the observatory to monitor the impact of that crisis and policy responses to that crisis on health systems in Europe. Marius has really reminded us that it's not just about finding the money, but how you find that money or how you try and reduce that gap has consequences and does matter. And so if you could, I have two questions for you. One, if you could just briefly expand on this idea that it's not really an accounting exercise and tell us how you think we should be thinking about this. And then second, so far we've really focused on the revenue side of things with good reason, because many countries will face a revenue-driven gap and will be able to hopefully do things about it. But there are countries like Spain that don't face that revenue challenge because they already have a very broad revenue base, but they will face a challenge on the spending side. So could you say something about some of the issues and challenges that countries may face in addressing the spending side of the equation?
Sure. Thanks, and nice to be here, even if virtual. Just maybe as an introduction to this, I want to say why I like the approach of the simulator is precisely in terms of informing and putting policy issues on the table, is that in effect it highlights a do nothing scenario, right? If you don't do anything and you just get demographic change, this is what's going to happen, with the message that, well, you better do something, right? So this is kind of, where policy takes off. So it's not the job of the simulator to build in all of those policy changes, but just to highlight these things, or put another way, that the idea is not to be right about the future. Unfortunately, it turns out from what Maris was saying that maybe those scenarios were more or less right about the future 20 years ago in Estonia, and now we're seeing it. But ideally, it is to influence decision-making today, right? So on this, and then maybe coming to this question of the financing gap issue, I think here, yeah, I've struggled with this because even at the global level, a lot of the discussion around UHC has been, well, how much does it cost to get there, and kind of reducing everything to just a kind of an accounting exercise, that if we just have this money, then everything will be all right. And really what I think the way to interpret the gap in the context of the accelerator is that there is going to be a gap in terms of the results that we're trying to sustain, right? And this is a way of really thinking about this sustainability question, not as kind of we need so much money and then everything's okay, but we want to sustain a certain level or a degree of improvement in what we care about in terms of financial protection and reducing unmet need, for example. How much we care about this, and this is kind of the underlying question, is the core issue of national values, right? And how much do we care about redistribution? We, in this case, meaning each country and the way this works out in the political context. But I think it's useful to really think about this gap in terms of we're not going to get the results that we need. And John was showing again, well, if you increase the spending by the out-of-pocket amount, assuming you don't have any unmet need, and you will have more, of course, then this is how it would play out in terms of worsening financial protection. So I think it's really quite important to not think of this just as, there's a gap, we have to fill it, but rather a gap really, in a way, we want to shrink it. And we want to shrink the gap in some sense, both by altering policy on the revenue side, and then critically altering policy on the expenditure side. And I think this is what you're referring to maybe in the second question for me. I think there's some valuable experience from many countries. I was going to look at one from outside the region in China, where from the early 2000s, there was a very large increase in the revenues put into the health system, right? So you could say that, okay, they addressed their revenue side problem mostly through a political decision to put more money into the system and link that to affiliating people to some sort of explicit coverage scheme, one of their health insurance programs. But they didn't manage expenditures. So basically you had problems of both provider payment policy, which is still paying largely on a fee-for-service basis, and on coverage policy, where you had still percentage co-payments, and the idea that you might shrink that percentage from a hypothetical 30% to a hypothetical 20% is kind of meaningless. You know, it's not, because in a way that too is treating the expenditure side as kind of an accounting issue rather than dealing with basically the incentives involved. So you need both provider payment methods that put a limit on, you know, in a sense, operate the system within a budget, and also coverage policy that also has explicit limits on people's co-payment obligation. I think what we can, so in a way, when we think about the spending side, actually, the other point that I wanted to make on this, which I think is important, and this is just going to be more technical than political, and we maybe come back to the political issues later, is that it's useful, and this may be too crude a way, but how an economist might say it, is to think about spending in terms of consumption and investment. Whereas on the consumption side, we have issues of what is our current expenditure, and the fact that there's already an existing risk mix. We may have a lot of people with chronic conditions such as hypertension and diabetes. At this point, their risk of needing services is 100%. So it's more a question of how do we actually use our money in a way that manages their care effectively. One way you can use instruments from health financing policy is, for example, to use the provider payment database to identify the kinds of conditions that are the main cost drivers and use that to develop kind of as an input to developing a kind of prioritized case management strategy for those high cost driver systems. So that's more on the consumption side. You don't have any magical health financing solutions for on the revenue side for in the context of people who already have 100% risk of needing services. On the investment side, there's really about what can be done, and I think that Dirk had mentioned this at the beginning, and maybe John gave some hint to this, that you also need to try and what used to be called bend the cost curve. How do we actually take action now that will improve people's health longer term, have them live healthier lives and not just longer lives? And that might be more the investment side of what might be deemed effective prevention, and whether that is certain types of healthcare interventions or other interventions around tax policy, you know, tobacco, alcohol, sugar sweetened beverages, food policy more generally. And again, looking at from countries outside the region, China, again, Mexico, another, where you've got big problems of childhood obesity, right? So your ability, you know, 20 years down the road to deal with the healthcare consumption side of that is going to be greatly challenged. So there are very strong arguments, I think, to say that, you know, given these scenarios that we have to do something in the short term in terms of dealing with the illnesses that we have, but we really need to do some interventions now to change our health risk profile in the future so that because if we don't, it means that our ability to sustain real progress on universal coverage is going to be much more difficult. So I'll leave it at that. Thanks.
Thank you, Joe, for sharing your thoughts with us. Thank you to all three of the panelists. If you have questions for the panelists, Maris, Jan, and Joe, please put them in the chat. Lynn, I'm going to go over to you now because the participants in this webinar have been very, very patient listening for quite some time. You've been monitoring the chat. Can you tell us what's been happening in the chat? Are there any questions for John? Are there any questions for the rest of the panel? Lynn.
Thank you, Sarah, and thank you, everyone. The chat has been actually very active, so thank you for all the questions and all the comments. I've also been posting a lot of relevant links. So we actually have participants coming from all over the world, including the countries that are in the study, so that's pretty nice. I will just read out some of the comments and questions that have been going on in the chat, and maybe panelists, you can jump in to try to answer. So firstly, there was a comment, after hearing about the French success story and seeing the findings from John's presentation, we discussed a lot about broadening the revenue base. So there was a question, initially it was targeted to John, but feel free to jump in. When we say diversify the revenue base, what do you think are the top 3 sources that countries could use to design their revenue streams? Because we want something that remains stable during economic downturns without relying on regressive taxation that disproportionately affects people with low income. So sort of 3 sources that you think could be used. Another one was about participants were agreeing that relying more on general revenues makes sense, but it's very hard to sell this to governments who argue that they don't have the fiscal space. So participants were asking what kind of advocacy statements could make the governments push them to make these changes. And then lastly, asking questions about whether the research accounted for potential shifts when it comes to workforce dynamics. So for example, increasing the labor force participation among older people, whether we've considered that and how might extended employment among older people might influence health systems revenue, but also overall financial sustainability. So I leave it on to you to hear your thoughts.
Maybe I'll go first because I've been quiet for the longest. And I tried to answer some of the questions in the chat, but as Lynn said, there were too many, so I got lost in them. But so it's good to have a few just to focus on. On this question about broadening the revenue base, I saw it in one of the other questions as well, commenting about this idea of the regressivity of VAT. And I think it's important to look more closely at this. You know, there's this oft-held belief that VAT is automatically regressive, so that the distribution will fall predominantly to poorer households. But this is not necessarily the case. Actually, there was a good paper, I think it was a couple of years ago, by the OECD Tax Center that reevaluated this idea of the regressivity of VAT and found that actually it's VAT is oftentimes proportional or even slightly progressive. So it depends on the exemptions that are in place. It depends on what you put reduced rates on. So I don't think that it's fair to say, you know, across the board, VAT is regressive. I think it depends how you design it. So I think VAT is good. I mean, at least from the perspective of population aging, it's the most impervious of the revenue, the forms of taxation to aging, because consumption is fairly flat over the life course. So whether you are 10 or 70, you are consuming relatively similar amounts in expenditure terms. Whereas in terms of, you know, it's wages for a 10-year-old compared to a 40-year-old are, you know, hopefully extremely different. On broadening the revenue base as well, you know, I think, and Jan talked about this in the French example, broadening from labor-related a tax on wages, a tax on labor-related earnings to a tax on income. I think that this is a good way to diversify. So it's not just that you're taxing work. This can also be a good labor market participation incentive, potentially, depending on how it's designed. And I think wealth taxes also, in a lot of countries, older people hold a lot of assets. And while they're not politically popular, coming up with ways to reallocate some of that wealth and put it to use, I think is reasonable. In terms of advocacy statements to make changes, I think we're not suggesting that countries with social contributions get rid of the mechanism of the social contribution tax, right? That if you're Slovenia or Slovakia or Bulgaria, don't get rid of the social contribution, but you need to come up with another way that is more, that is not as pro-cyclical or as easily affected by aging to maintain the stability of revenues. So maybe this could be something like having a target share of the overall government budget to pay for healthcare, but the suggestion, or removing the hard earmark for social contributions, but the suggestion is not to get rid of the social contribution necessarily. If you're able to collect public revenues, you should continue to do that. The other question, and I'll pass it to the other panelists, on things like raising the age of employment. I think this was question 3. Yes, I mean, we, as Joe said, you know, this is if nothing changes type of scenario. But in the PASH simulator online, you can simulate the impact on things like social contributions of raising the retirement age. Of course, we could do that as well. We didn't do that for this particular paper because the combinations of different policy mechanisms that could be explored is endless. And we wanted to propose to put forward really, this is how things will be if nothing changes. But absolutely, raising the retirement age in line with increases in life expectancy would produce changes. That being said, I mean, keep in mind, the countries that have very small gaps, like Bulgaria, still have extremely high catastrophic spending by the end. Slovakia as well has a very large gap, but also this huge increase in catastrophic spending. So I think a key takeaway message is not just to focus on the revenue raising, but also to focus on user charge policies and making sure that there will be a gap no matter what. If you think about it from a very strict accounting perspective, as we have done in this exercise, there will be a financing gap. And so ensuring that any increased burden of paying for healthcare out of pocket doesn't fall to households that have the least capacity to pay is really key. And the only way to do that is through strengthening copayment and user charge, copayment and coverage policies. There's my quick answers, but I'm sure there are others that have comments as well. Over.
No. Your hand is raised.
Yeah, just one, well, two things. One is that just to say that I'm glad after hearing John's talk about raising the retirement age to know that I just personally extended myself here to retire 5 years later. So I have the joy of making my social insurance contributions for the next 5 years here in Switzerland. So that's reassuring to know that I could somehow be in the simulator. One thing I just wanted to make one plea really on the data side of this, which is that it would be hard to even have this conversation if we didn't have the data showing that that basically there are multiple sources to social insurance programs, right? For those countries that have such schemes, this is something that WHO started reporting a few years ago with the revision to the system of health accounts. And while it doesn't have, and we don't expect that system to have the disaggregated detail on the type of tax, the fact that we have this information basically, and that it's not that hard to generate really once you're generating information through WHO, through OECD, or even Eurostat to produce this information that basically is able to tell you, what share of spending in whether it's Estonia or France is coming from the payroll contribution versus general budget transfers. That is really important information for policy that has helped, I think, especially in the early years, drive these kinds of considerations, not just in high-income countries, but in countries of all income levels. And just to make a plea, as I've done in the past, while WHO reports that data for OECD, in particular Eurostat, they continue to treat that as a voluntary option. And there's no reason that should be voluntary, that this is something that all countries should do in order to provide a basis for decision-making on this. So I think it's quite helpful that we have the information and just want to encourage more to do it. And certainly in any country-specific analysis, as John was showing, then you can break down much further into the types of taxes and really look at these different options. Last thing on this, and going back to that question about, and John raised about, do we stop payroll tax and so on? I think the answer is no. Fundamentally, I think part of the logic of separating the revenues and expenditures is to say that where the money comes from, fiscal space questions on that side, is fundamentally a tax policy question. It's not a health policy question, right? So whatever the country's tax authorities are doing, and that tax policy should incorporate the implications of demographic change as well, right? So, I think our job in the health sector is to say that if you only fund the health sector by one type of tax largely, then you're leaving yourselves quite vulnerable, not only to demographic change, but as we saw with COVID, also to employment shock, right? And so you want to have some diversification to enable the system to be more resilient to those types of shocks. But it's not so much, other than health taxes, our job in the health sector to tell you how you should raise taxes or which ones to use. Thanks.
Marius, go ahead, please.
Thank you. I would like to continue from the diversification of the revenue base, and I'm really happy that Joe brought it out, that it's not only about the proportion of social health insurance versus the proportion coming from the general revenues, but it is about what you levy the social insurance contributions on. And as Estonia started its economic transition in the early 90s, with the classical labor market, the long-term labor contracts, and we missed out on the moment when we transitioned into more service economy with more flexible working arrangements, people becoming more self-employed, working through their own small companies, taking out dividends instead of paying salary to themselves. So we are not taxing with social contributions the kind of the passive income of people, the same that Jan touched upon, the fairness question. And this is where the Estonian kind of political reluctance has been, that on these more right-wing political families, that they are not willing to discuss taxing passive income of households, and rather talk about taxing labor and playing around with labor tax versus out-of-pocket payments. So don't miss out on the moment when the share of passive income starts to increase, that you are able to tap on it before it becomes too big and more difficult to handle.
Thank you, Marius. And Jan, can I bring you in here? Because when we talked before, I mean, you managed to do what you did in France, but what advice would you give to Marius in Estonia or to other countries in terms of how to approach this? And what benefits did you see from the CSG that could speak to some of these issues that both Joe and Marius have raised?
I would say I have to be honest. We did not find the philosopher's stone. I mean, we have to admit that CSG is 2/3 the same base, the same tax base as classical social contribution. So it's not such a huge diversification. It's a partial diversification. And although CSG has taken a rising part in financing healthcare, we still have something like 40–50% of healthcare, which is funded by social contributions. So it's not a radical shift, it's a complementary revenue. If I had to give additional advices from our French experience, the first one would be to use the fact that you have a broad base to start with a small rate. It's much more acceptable to start with 1% or something like that. 1%, because you have to know that all these shifts will, in the end, reduce the purchasing power of capital incomes of pensions. So you have to be really progressive in this diversification. It took us something like 30 years to rise 9%. The second advice would be to really take into consideration the situation of pensions and small pensions, because first, when we created the CSG, we had to take it in consideration, and each time we had to rise it, we had to take in consideration the situation of small pensions. And I have to say that although in France we have quite good pensions in comparison to other countries, so maybe especially in countries where you have a topic about the purchasing power of pension and the way of living of retired people, you have to anticipate a solution for small pensions to make it acceptable when you create and raise this new tax.
Thank you, Jan. And Lean, are there any more questions in the chat, or do we have just one or two last questions for the panel?
I don't think so, Sarah. That was pretty much the whole discussion summarized.
Thank you then, Lean. I'm going to then hand back to the panel and say, do you have any closing thoughts that you want to make? Any of you? Otherwise, I'll ask Joe to close the webinar. Maris, Jan, any final words?
Just to thank the Barcelona office for the work that you are doing. So genuinely, thank you, especially in these kind of let's be honest, dire times in Europe, and especially in Eastern Europe. We need the kind of support to keep the issues on the agenda that nationally might not be possible with reprioritization of security over health. So thank you and keep going strong.
Thank you. We don't give up, even if it takes us 15, 20 years.
Exactly.
Joe, I'm going to hand over to you now for your closing remarks, and then I'll wrap up the webinar. Thank you.
Thanks. And yeah, I mean, I don't have a better closing than what Maris just said. You know, and yes, we have to stay the course. I guess I would come back a bit, and it's related, you know, that there's different windows on issues, right? So this is a health financing and a window in a sense, and a health sector window on the more fundamental question for each country and maybe each person of kind of what kind of society do you want to live in, right? And so that question of, you know, the way I would frame it technically is, you know, what is it that you're trying to sustain when we talk about sustainability? Because having a health system or a social welfare system is not just, you know, it's not just an input. Those things exist for a reason. And, you know, in line with, yes, the challenges in the world today, they are obviously financial, they're obviously security, but there's, I think, at the core really about, you know, what kind of society do you want to live in? And so it's a challenge, especially for those that profess democracy, because you have to, and these types of issues, and it came up in some of the questions that were said, the types of issues about, well, we have to think about the future and what kind of society do we want for our children, I think is a very difficult one nowadays, because there's so many short-term needs that have to be addressed and short-term demands. But I do think it's still helpful that wherever any individual is in terms of, you know, their values and what they want from their societies, you still need information to try and make these decisions as rationally and dispassionately as possible. But there's no getting away from the fact that, especially when we talk about, and it was helpful that John showed this in the pictures, that we're not just talking about some achievement of some threshold, but we care deeply, at least as reflected in the analysis, presumably, about the distributional consequences of the changes that are happening. That, you know, again, if we don't do anything, then these things will get worse. So I think it's really just a good reminder that, you know, whatever the technical topic is nowadays, fundamentally there's some normative element which is driven by you know, a value position of what it is we're trying to achieve. So I think it's useful, and maybe we can't avoid it anymore and take things in a purely technical sense, but to maybe be very explicit and intentional about that as we go forward. And part of that is to be able to communicate about that. It's nothing to be ashamed of, right? It's something in a way to be proud of. So I think we have to work out how people who are able to put things much more succinctly and clearly than I can carry forward those kinds of messages for the world. So thanks again, to add my thanks to everybody else here, and thanks to the team. And back to you, Sarah.
Thank you, Joe, for encouraging us to not do nothing and also ensure that we do the right things. I want to thank you very much to all the panel. Thank you, Maris. Thank you, Joe. Thank you, Jan, for joining us today. Thank you, John, for your excellent presentation. Huge thanks to the European Commission through the EU for Health Programme for supporting this work. And thank you, Dirk, for making those excellent remarks at the beginning. We put John's slides and the reading list for today on the chat for you. All our resources are on our platform, UHC Watch, so please check that out. We've now got 2025 information on coverage policy really up to date for a lot of countries already. Please sign up for updates on our work if you can. And I just wanted to let you know that if you can join us on the 26th of May, we'll be having a half-day workshop on these issues, a lot of health financing issues, on the issues of affordable access to healthcare. If you're in Brussels, join us in person, but it's also going to be online, a hybrid event. So join us then, I hope. Thank you again, everybody, for joining us today, for all your questions and your activity in the chat and your interest in this. And we hope to see you soon. Thanks so much, everybody. Bye.